My name's Dr. Janet Rimmer, and I'm a respiratory physician, head of the department at St Vincent's Private and St Vincent's Clinic. And it's my great pleasure to have with me today a colleague, Dr. Anthony Byrne, and he's going to be especially useful as he's working at the coalface with COVID-19 cases at St Vincent's General Hospital. So just a couple of housekeeping comments at the beginning. If you have any comments or questions, please put them into the comments box and we'll try to answer them at the end of the session. And also just to remind you that the information that we're going to provide is general information, and you may wish to discuss it further with your GP or your own respiratory specialist. So I'm going to start off by asking Anthony a couple of questions which just underlie the whole coronavirus pandemic. So these are: what should I do if I think I have coronavirus, and when should I get tested, and when should I go to hospital? So Anthony, over to you.
Thank you. Thanks, Janet. So they're really important questions, and I think a lot of the population out there will have these questions in their mind. Certainly a lot of our patients have been asking us these questions. So it's important then to know what the symptoms of COVID-19 or coronavirus are. And if you're not aware, then the key ones are fever. So a fever, a temperature that's measured that's 38 degrees or above, and respiratory symptoms. So respiratory symptoms such as cough, sputum production, and a particularly concerning one is breathlessness, particularly shortness of breath at rest. So these symptoms are certainly what we find in people with coronavirus. And it's important to mention that they're also found in a lot of other respiratory conditions. And a lot of our patients, in fact, with chronic respiratory disease will have a lot of these symptoms on a day-to-day basis. So one of the important points is it's a change for how you're feeling normally. So if you normally have a little bit of a cough and sputum, but then you feel particularly unwell and you've got more sputum and more cough and you have a fever, then certainly that could be from coronavirus. It could also be from many other respiratory infections. And so at that point, you would be eligible for testing if you live in one of the hotspots, which we have certainly around our hospital here in Waverley, but also if you see your GP or healthcare professional and they've taken a history from you and examined you and they believe that the diagnosis could be coronavirus, then they can write a referral for you to get a test done. And that test done is done at different private pathology providers, and we have also public providers just near the hospital here in Byrne Street. We have a testing facility, and the test is a nasopharyngeal swab. Some of the nurses affectionately call that a brain swab because it can feel a little bit like it's touching your brain. It does go back a long way. But that's the test that's done, and the result can come back pretty quickly, certainly within 24 hours, and if not less. So that's the way to get tested for coronavirus.
And when do you think people should think about getting the test? Sort of as soon as they feel unwell, and how quickly should they go and get the test done?
I think patients should get tested when they meet any of those criteria. So if you've got symptoms like that, certainly with the fever and those respiratory symptoms, get tested. And we're certainly lowering the bar, and you've seen that over recent weeks with the criteria for testing being broadened, so that now the bar is quite low, but it also always includes symptoms. So anyone with a fever and those symptoms should potentially get tested. And that will do a couple of things. It will allay their fears about the virus, and it will also provide an answer for their symptoms. Another question that you asked was, when should you think about going to hospital? And this is difficult, but it should be when you're really worried. But also it should be when you're concerned and you're getting worse. So one of the things that I've been telling my patients is, because we're dealing with patients with chronic respiratory disease, and a pulse oximeter is something that can be useful in patients that have chronic respiratory disease. And an oximeter is a way of measuring the amount of oxygen in the blood, and that can be a useful a useful piece of information. But in general, it should be discussed with your doctors, and we're lucky at the moment is in that you can potentially see your doctor from home via telephone consultation. So certainly, if you're concerned enough, then that's when you should come to hospital. Certainly, red flags to watch out for would be breathlessness at rest. I think breathlessness at rest, chest pain, symptoms that aren't responding to a self-management plan that maybe you've got in place for your asthma or your COPD. That's the time to come to hospital.
Yeah, I agree with that. I mean, I usually say to people, if you're really struggling with your breathing, that's the time that you need to consider coming into hospital. And, I think that's a very scary decision for patients because you see a lot of the dreadful pictures on the news. But look, I mean, hospital is where you get supportive treatment. And there's one success story that we know. Boris Johnson went into hospital and he's come out looking quite well. So it's not that everyone who goes into hospital ends up on a ventilator. They don't. To begin with, it's supportive therapy. So, people don't get onto a ventilator unless they really need it. So that would be the best time to go to hospital when you're in what we call respiratory distress or you're struggling with your breathing. So we talked a bit before, Anthony, about how often would you test for coronavirus and do you need more than one swab? So what's your experience with that so far?
Yeah, it's an interesting question, an important question, and it gets back to how good the test is. And there are different tests, and they're all not the same. Some tests actually have the ability to test for more than just coronavirus, and that's really useful. And we have that at St Vincent's here, where the infectious diseases doctors have very cleverly added the coronavirus test to a standard panel of respiratory viruses. So it means that if we do a test when a patient has symptoms of fever and cough and the coronavirus test is negative, but another pathogen such as influenza or rhinovirus is positive, then it potentially explains their presentation and it makes it then less likely that they have two things going on at once. But we do know with this test that it can be wrong, like any test. And so we have to put it into the big picture and the clinical picture and see how likely it is that this person has coronavirus before we even do the test. And that's something, a concept called pretest probability. And it does help us a lot. But we certainly see that the coronavirus swab test can be negative. And it depends on the type of test. It might be 70% of the time that it's sensitive to getting it right. And as high as maybe 90%. But we certainly have seen here in the hospital where patients have had a negative test result, but we really thought that they had coronavirus because of their travel history or their clinical presentation. And so we did another test after 24 hours. And the one that I'm thinking of, that test was actually negative as well. And they went to have a third test, and it was only the third test that was positive. So we do have to keep this in mind of, is there an alternative diagnosis? And I think that's really important to explain their presentation. And if there's not, but we really think that it's likely they've got coronavirus, then we'd repeat the test. Another thing that's important is chest imaging and other complementary tests. And we know that the chest x-ray is a very useful test for diagnosing respiratory diseases. It's not that sensitive in coronavirus, but the CT scan is quite sensitive, and some people are actually quoting sensitivities of over 90%. And I was on a call last night to one of the radiologists in the States, and she was going through in quite a lot of detail some of the published studies of describing the CT findings in coronavirus and her experience there in the States. And there are characteristic appearances on the CT scan that will make us more thinking that that coronavirus is the likely diagnosis, or in fact there's an alternative diagnosis.
Yes, I mean, I think the Chinese used CT scans very extensively, and their comments were that really all people who were admitted to a hospital with COVID-19 pneumonia, nearly 100% of them had an abnormal CT scan. So I think that's a very useful investigation. So we'll move a little bit now to another question which often is very relevant for patients. So if you have an underlying lung disease, is that a risk for COVID-19 pneumonia? And there certainly is data from China and from Italy saying that if you have a condition called chronic obstructive pulmonary disease, then yes, you are at increased risk. Now, chronic obstructive pulmonary disease, particularly in China and Italy, but to some degree in Australia as well, is usually people who have smoked for many years and they end up with chronic bronchitis and or emphysema. And these people will have reduced lung function. And we know from the overseas data that their mortality when they have COVID-19 pneumonia is sixfold. So if you are in that category, then you need to take very seriously the concept of self-isolating. And you need to have a very frank discussion with your family about, where and how you should self-isolate. So you would be considered a person at high risk. But there are other risk factors as well. So underlying cardiovascular disease, diabetes is a risk factor as well. And unfortunately, age is also a risk factor. So the older you are, the less well you deal with coronavirus. And the mortality rates start to increase from the 60s, 70s, 80s, and 90s. And if you look at the Australian statistics, nearly all of the people who have died so far, and I think this morning it was 72, nearly all of them are older. And unfortunately, quite a number of them are elderly residents in nursing homes. So age is definitely a risk factor. So we might talk a little bit now about pre-existing treatment for people with lung disease, and in particular use of things like inhaled steroids. So Anthony, do you want to make any preliminary comments about that? I mean, steroids, I think we need to talk about inhaled and then oral steroids, as they are quite different.
Yeah, these are an important class of medications that we use in a lot of our patients with asthma and COPD, and I think it's important for our patients to be aware that these medications should be prescribed and hopefully are prescribed for a good reason. And so patients certainly shouldn't just stop their medications without speaking to their GP or specialist. But theoretically, there is a concern, I guess, about inhaled corticosteroids and oral corticosteroids increasing the risk of infections and the risk of pneumonia. I'm not aware of that data being specific to coronavirus, though, and interested in your thoughts, Janet, on inhaled steroids.
Yeah, well, certainly I think in the asthma world, there have been some fairly definite position statements come down that say if you have asthma and you're on inhaled steroid inhalers, you continue those, you do not stop them. If you did want to change the dose, then you need to discuss it with your GP or with your respiratory specialist. The issue here is that if you do stop your treatment, then you will get a flare up of your asthma. And you may then find that difficult to know whether that's asthma or whether you think it's a coronavirus infection. So we don't recommend stopping inhaled steroids. The other thing to say about inhaled steroids is that we do know that they significantly reduce mortality due to infections and exacerbations or flare-ups due to infections. So overall, it is really important to continue your inhaler medications. Oral steroids are a little bit more tricky. Usually that means that you've got a severe underlying lung disease, which is not manageable with inhalers only, or you may have other reasons why you're on oral steroids. And we do know that oral steroids do suppress your immune system and they are associated with an increased risk of infection. So if you're very concerned about this, again, you need to go back to your specialist and discuss this. But don't stop without having a discussion with your treating medical practitioner first. Now we'll move on a little bit to use of equipment in the home. So quite a number of you may have nebulizers or CPAP machines. So Anthony, you're a sleep disorders physician. So what do you feel about the ongoing use of CPAP machines? Is that a good thing or a bad thing?
Well, I have to say that they're a good thing. So CPAP's great for a lot of things, particularly obstructive sleep apnea, and a lot of our patients, they'll be prescribed the CPAP machine for their underlying sleep disorder, which commonly would be obstructive sleep apnea. And the reason they're prescribed it is because we know that often it will make them feel better, and they get a really improvement in their symptoms of daytime sleepiness, and also there's an association with other medical problems. So a bit like the inhaled corticosteroids, we would strongly recommend that you don't stop your CPAP machine because of concern of coronavirus. It is theoretically possible that with CPAP that you can aerosolize the virus, which is found in the respiratory tract. And so there is, via the CPAP mask, there can be leak around the mask. And so you can get aerosolization of the virus to the room in which the patient's using the CPAP, or obviously when you're using a nebulizer for salbutamol or other medications, that can happen, and that can be a risk for other people in the room. Of course, that assumes that the person is infectious and has a virus, and that's usually not the case. And it's also important to say that you're in your own home when you're using this equipment. So the only person you're going to infect potentially would be yourself or the other people that are in your home. So it is potentially relevant in that situation, and we do have patients that are in the community. And in fact, it's important to point out that maybe 80% of the people with positive coronavirus have a more mild sort of course, and those people should certainly continue to use their equipment at home, but with the proviso that there is a potential to aerosolize the virus. And so people that are in the same bedroom, for example, would be potentially exposed to that virus if they weren't already. So it is relevant for the people that have coronavirus that are self-isolating for other members of their household. But if that's not the case, then people should continue to use their equipment. In terms of the nebulizer, we do know that the inhaled with a spacer, salbutamol with a spacer for most people can provide can be just as effective as a nebulizer. So there may be an opportunity to use that instead of the nebulizer. In the hospital environment, it is a little bit different, and we have to consider the space and the other patients that are in the hospital. So we do in the hospital try and limit the use of nebulizers and CPAP machines and BiPAP machines. We do have to think about the infectiousness in a hospital setting, but in a home setting, that's usually okay, except for the caveats that I mentioned.
Yeah, no, that's good. And so lastly, we're just going to talk a little bit about exercise. So exercise is really important, and these days probably more important. It's one of the reasons we're allowed to go outside. Indeed, we're encouraged to go outside, and I think it's good for our mental health just as much as our physical health. So a lot of people with chronic lung disease have taken part in pulmonary rehab programs, and they may still be enrolled in these, but the face-to-face programs at the moment have been put on hold. However, it's important not to stop exercising, and we know that exercise is really good for people with chronic lung diseases, whatever the underlying chronic lung disease is, and it's very strongly encouraged that people continue to exercise. So what can you do if you have a chronic lung disease, you were in pulmonary rehab, and now the program is closed? You can talk with the pulmonary rehab people and ask what exercises you can do at home and how much you should do in terms of going outdoors. But a lot of the physiotherapy services, they will provide a video link program. So the ones here through St Vincent's Private will do it through Zoom or through FaceTime, and they will do an individualized program which will run for about 45 minutes or an hour. Or the other alternative is that you can organise a face-to-face session with a physiotherapist. Now, all of these options should be discussed either with your GP or with your respiratory specialist, and they can refer you into these services. So, Anthony, any other comments or questions as we've gone through all of this information?
There's a lot to consider, isn't there,
Mm.
in the current COVID pandemic? I think another important point that a lot of people are becoming concerned about, I think, is with the home isolation, that there are a lot of other chronic medical problems that are being sort of put to one side. And so I think it's really important that everyone out there, COVID's really important, but so are all the other medical problems that we were dealing with up until 3 months ago, when no one knew what COVID-19 was. So I think it's important to consider those things, and we're lucky to have the ability to consult with our medical providers remotely using this sort of medium. So I think I'd just encourage people to take advantage of that, because I think there's been a lot of a drop off of patient attendance at GPs, and that's probably been two ways, both from concern from the GPs but also from the patients. So maybe in the current environment, where it's looking like we're making some gains against the virus, that's probably the next thing to consider.
Yeah, look, I think telehealth has been a really important advance. We've all had to learn to do it very quickly, but the government has supported it, and I think that that's also really important. And, you know, I think as patients, it is something that you should consider to take advantage of. So thank you very much, everyone, and we're happy to go to any questions.